Welcome everyone. This is a new vlog of our MIDAS Simplifying Health Economics series, and today we're going to talk about supplier-induced demand. Luís will now talk about the theory behind this concept, and then Misael and I will talk about practical examples where supplier-induced demand can produce some effects on the healthcare system. So, Luís, over to you now with the theory behind supply-induced demand.
Okay, thank you. Hi, everyone. And let's start talking about what brings this problem of supply-induced demand. So at some point, probably in our series of videos, we have talked about the specificities of the healthcare market compared to traditional markets. Still, I'm going to make a very, very brief summary, which is the following. In traditional markets, you have probably heard about the concept of the invisible hand from Adam Smith. And the idea is that if there's no market failures, or if they are not very significant, in a market where two agents interact, so that the supplier and the producer, or if you want a layer term, like the buyer and the seller, eventually they find out through interactions what is the equilibrium in the market. Now, the thing is that when you have what we call these market failures, this doesn't happen. They will find out some sort of equilibrium, but that equilibrium is not going to be the one that maximizes the welfare in the society. So it will not be a true equilibrium. And you have here a list of potential market failures. And healthcare markets basically have them all the types of market failures that you can think about. But today we are going to look at one very specific market failure, which is asymmetry of information. And we are going to look at one part of that asymmetry of information, which is the following. The doctors, so the healthcare professionals, usually know a lot more, well, they should know a lot more about medicine than the patient. So if I go to a doctor, I will know that I'm suffering from something. I will know my symptoms, but I will not know what to make out of it. Like I cannot understand what will be my disease. So I will go to the doctor, and the doctor will interpret my symptoms and will try to come up with a diagnosis. Also, the doctor is the one that will know how to come up with a treatment, and before that also how to do the diagnosis. So this imbalance in terms of information can potentially create some issues. Now, before we talk about the issues, we need to understand the concept of agency. So the physician is considered to be an agent of the patient, in the sense that they should act in the best interest of the patient. So the patient delegates a responsibility to the physician and needs to believe that the physician is going to do the best to help the patient. However, while that should be truth, while that should be true, I believe that physicians do care about the patient. They have things they have their own interests, and things that influence their utility. Do you remember utility from another of our videos? If not, utility is like happiness, welfare, and those things, making it very, very simple, should be something like effort. Like everyone, when you work, you don't like to exert as much effort because you would like to have more time for leisure. For example, if you have to work more, you don't have as much time for leisure. It should be income, of course. You work in order to receive some income, to receive some money that then you can spend on consumption. But then we actually believe that in the case of physicians, patient well-being is also important. So this level of agency where actually the physician wants to do the best for their patients. But this can conflict. For instance, if you want to do the best for the patient, you probably need to do more effort. But if you do more effort, you have less in terms of leisure time. So one increases your utility, but the other one may decrease. Like even income, this doesn't probably happen in the NHS, but if you go to a private doctor, how can you tell that they would not want to make more income out of you? For instance, making you do more tests, more exams, etc., so that they can have more income, so that they can have more consumption and be happier in that sense. So the income can also go against the patient interests. Okay, and this is precisely where the idea of supplier-induced demand comes from, which is that the doctor can make you do things that actually you don't need that much, so that they can make a little bit more money and that they will be happier because of it. So because of that, we have the so-called physician's pledge, where you can see I highlighted two things in the oath, like the health and well-being of my patient will be my first consideration. I will respect the autonomy and dignity of my patient. I will share my medical knowledge for the benefit of the patient and the advancement of healthcare. In fact, these topics here, these items in the physician's pledge, are actually the acknowledgement that sometimes physicians' incentives may not fully be aligned with the patient's interests, and that's why they need to make an oath, so that hopefully the oath and the dignity of the people who take the oath can lead them to be more aligned with the needs of the patient. So just summarizing, what is then supplier-induced demand? Is this idea usually that the doctor may make you do more stuff in order to potentially, for instance, make more money. Now, you will say, oh, but that doesn't apply in the NHS, and it's true, it doesn't apply as much because most of the people in the NHS receive a fixed salary. So even if they make you do a little bit more stuff, like they won't make any more money out of it typically. But this is a big problem in private markets. For example, this is a big problem, can be potentially, so I'm not saying that it is, but can be potentially a big problem in dental care, where it's typically private, or it can be a big problem in other countries where the private system takes a little bit of a bigger chunk of the entire health system, like for instance in the US, where it's mostly privatized, or even other countries where the market for private healthcare is just a little bit bigger. Now, just before I give it to Valerio to give you some examples, let me just say that there are some hypotheses around this idea of supplier-induced demand. One of them is the target income hypothesis. It's a little bit of an old hypothesis with lots of criticisms, but the example that Valerio is going to give you actually fits within this hypothesis, which is imagine that you have a healthcare market where the physicians are providing some type of service, and suddenly for some reason there's a lower demand for what they are providing, or there's a bigger supply, so more people providing the same service, which means that the price should go down and they should make less money. And the idea of the target income hypothesis is that if physicians believe that they are going to make less money, they can start inducing more and more demand. They can start telling, for instance, patients that they need to do more tests, or that they need to do more expensive treatments and so on, so that their income doesn't go down too much, and so that they can keep the same level of money they make and the same level of utility. Then, of course, you have the typical profit maximization hypothesis, which is just saying that if I'm a seller of anything, even if of healthcare, I want to maximize my profits. I want to make the most amount of money I can, which can imply that I can induce some demand in order to make more money. And then you have things like defensive medicine theory, or even bounded rationality. Defensive medicine would be, okay, because I'm afraid that my patient may be hurt, even if the likelihood is very low, may be hurt if I don't do enough tests or enough treatment or so on. I'm going to do more than necessary to be sure that nothing happens. Or bounded rationality can be something like, sometimes physicians believe that some treatment is amazing, but then it is not, and they just go to the most expensive, the newest one, because they think it's the thing. and then it is not. So for bounded rationality, actually, I would advise you to go to our RACES program, where we one of the things we do is try to help physicians and other healthcare professionals understanding the effectiveness and cost effectiveness of new treatments. So just a little bit of advertising. So I'll give it to Valerio to give you some examples of supplier-induced demand.
Thank you, Luis. Now I'm going to talk about a practical example where we can see how supplier-induced demand works in the real world. And I'm going to talk about a seminal study which was conducted in the US. It's the study conducted by Gruber and Owings. It was published in 1996, so a bit old, but as I say, it's quite seminal in terms of understanding how financial incentives might drive physicians' decisions. In particular, we are looking at cesarean section deliveries. So we're looking at whether, again, financial incentives might have a role, play a role in terms of performing more C-sections. And the premise was a fall in the fertility rates in the United States between 1970 and 1982. So it was probably a 13-14% fertility rate fall during that period. And the hypothesis which was tested by the authors of the study was around understanding whether there was an increase in the number of C-sections during this period. In particular, whether this increase was driven by financial incentives. So, of course, C-section tend to be more highly reimbursed compared with normal childbirths. So, where we have fewer births overall, maybe physicians have an incentive in order to perform more C-sections in order to get more reimbursement that way. So there is a bit of limitation on the income side, which is presumably compensated by producing more or performing more expensive procedures. So the question posed by the authors was to see whether in states where fertility was falling the most, this section delivery rise the most as well. Now, there might be other explanations behind the rise of C-sections. Of course, some of the explanations which were discussed by the authors were around the fact that C-section or the procedure around C-sections enabled physicians to control the fetus better than compared with the past procedures. So, for example, the introduction of electronic fetal monitoring could improve birth outcomes. Another reason discussed by the authors was regarding the increased threat of malpractice legal suits. So that could be something that the physician saw as a potential threat, and then they decided to perform more C-sections that way and avoiding maybe the complication of a normal childbirth. Now, all these possible explanations, particularly around the legal suits, improving birth outcomes, they're all substantiated by mixed findings. So it's not always true that the C-sections improve birth outcomes, at least for the period in the study. So the authors try to disentangle the potential causal inference between the fertility rate fall and then financial incentives and a rise in C-section delivery. Now, to give you a bit of a graphical representation of what happened during the study period and beyond as well, this is the rate of the C-section deliveries between the 1970 and 1991, and you can see the first line, the top line, represent the total C-section delivery rate. In particular, between 1970 and 1974, the rate nearly doubled, so we moved from nearly 5% to nearly 10%. And then it doubled again between 1974 and 1984, so we moved from 10% a year to around 20% a year. So that really gives you an indication how there was a little, let's say, use of C-section in the early 70s. I think it was about 5-6% of all childbirths were delivered using this procedure, and then it rose dramatically during the 70s and as part of the 80s as well. The bottom line instead outlines the primary cesarean rate, so that is the rate representing women we went through C-section for the first birth. And again, you can see that rose dramatically during the study period. Now, what are the key results of this study? So the authors found a strong correlation between within-state fertility declines and within-state increase in C-section delivery rates. In particular, they quantified this association, and a 10% decline in the fertility rate was associated with a 0.97% increase in the C-section delivery rate. And importantly, going back to our concept of supplier-induced demand, financial incentives played an important role in the substitution of C-section delivery for normal childbirth. Now, the authors also underlined that, financial incentives played a role, maybe not a so prominent role. They quantified that financial incentives, for example, contribute to explain between 16 and 32% of this substitution. So there are, of course, other factors which are important, and the authors took into account in their statistical analysis. Overall, the final message made by the authors of the study is that when it comes to reimbursing for certain procedures, the physician reimbursement should be decoupled from the cost of a specific technology. So in this case, C-section is considered actually quite inexpensive, but for other technology, which could be quite expensive, that cost should be decoupled, should be separated from what we are going to reimburse physicians for their work, in order to avoid situations where, for example, the additional benefits of a new technology, a new procedure might not outweigh the additional cost. So this is an example of coming from the US, and now I'm going to leave the stage to Misael, who's going to talk about another practical example.
Thank you, Valerio. And this is another example. This comes from Spain. And in this case, there is not a financial incentive, but is a convenience incentive. In this chart, these authors, which published the paper in 2018, examines data from public hospitals in Spain from 2014 to 2016 and plot the hours of elective C-sections. And you can see here in this spike that there are an increase in the rate of C-sections between 11 p.m. and 3 a.m. So during this peak of hours. So what happened is that the hypothesis is that there could be a C-section because of convenience, because vaginal delivery could last up to 12 hours. So they need to examine again, they need to prepare women, and then they could last up to 12 hours or even more in some cases. Instead, C-sections could just last 30 to 45 minutes. So you can perform a C-section and then you can rest after that. So you need to wait. You don't need to wait all the night for a child delivery to happen. So, and they found that effectively there is a relationship between the hours of the nights and increasing C-section rates, and increasing C-section rates and a reducing of Apgar score, which is a health outcome for newborns. So this is measuring the skin, the brightness of the child. So dissections is causing harm to babies. So this is an interesting paper. But it's not only in C-sections. So, and it's not new. This phenomenon is studying for decades. You can review articles from the 1970s. They can see, look, there are a lot of surgeries, and here we have an example from the US. So that was performing unnecessary C-sections, and then we have an example from the NHS, okay? And then we have example from the European, from Europe, so in Austria, Germany. So what is happening is this is not a phenomenon that is only for one country or other country. This is from around the world. So, and we have more evidence from higher income countries because they got more data sets, but it's still true in other kind of settings. Then, what are the options? So, the NHS proposed the funding or reducing the funding for 17 unnecessary procedures in 2018, for example. So they did some analysis and they said, okay, there is some evidence that these kind of procedures are not effective, and if some are effective, are not cost effective. So they try to reduce, for example, in I think we can see here varicose vein surgery, removal of benign skin lesions, tonsillectomy, and so on. So, and then what is happening as a response of this phenomenon is that they are doing more research on identifying possible unnecessary surgeries. So the option for policymakers are more studies and regulation, which is another branch of economics which could be explored in other type of literature. And then over to you, Luis, so you can explain a bit more what more options we can have.
So, thank you so much, Valerio and Misael. I hope that your examples were nice for the public watching us. Just to finish, let's say what can then prevent supplier-induced demands. And it's basically playing with the incentives that I talked to you about before. So, for example, physicians not being paid by the fee for service and instead being paid by salary, like we do in the British NHS or even the Portuguese or the Spanish or other countries that have that style of system. If you have a salary that is constant, then you are less likely to make people do more because you are not going to get so much out of it. Now, it's not that the example Misael did was about the effort. So there maybe if you increase the costs of effort for things that you don't want physicians to do. For example, imagine they were doing the C-sections at night. Maybe you need to make them explain very, very, very well why they want to do a C-section, and then by increasing that cost of effort, they may not want to do it because you are basically balancing the effort that they don't want to do by waiting with the effort that they wouldn't want to do by filling a lot of forms. Then you have the ethics codes, which I just show you, for instance, in the physician's oath. Better informed patients can also decrease the potential for supplier-induced demand, because if patients know what they need, then the asymmetry of information is lower, and healthcare professionals cannot fool them. Long-term relationships are also important because those are on the basis of reputation. So if your doctor is fooling you, then you leave the doctor, and the doctor is going probably to lose money in the future because you would be a patient that would be there all the time and giving a lot of money to that doctor. So that reputation part is an important one. And there's then less uncertainty in clinical practice. So if you know exactly what are the best, more effective or cost-effective type of services, then you know which ones the doctors should use, and then they have less room to choose the ones that they like, the ones that will give more money, because they need to follow the guidelines and go for the treatments that are the best ones for the cases that they have. And then again, in this last one, please check our things on effectiveness and cost effectiveness analysis. And I believe that is all for today. Hope you liked it, and see you in the next one.